Before asking how wide the surgery should be, ask what the exact pathology diagnosis is and which feature changes the plan. Wait, hold on. What does that actually mean in practice? I mean, isn't rare skin cancer the diagnosis?
Right, and that's exactly why we need to pause right there and look at this quote. Let's set the foundation here. Getting that exact pathology diagnosis and understanding its specific features is literally the thing that completely dictates your entire treatment plan.
This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist.
All right, Section 1, start with exact pathology. You know, the phrase rare skin cancer can sound pretty frightening, but medically speaking, it's actually incomplete. It just doesn't tell us if the tumor is merely a local margin problem or if it's something that naturally travels to your lymph nodes and distant organs.
So let's break this down into 3 straightforward steps. Step 1, get the exact pathology name. Step 2, check if the biopsy was deep enough to actually show the bottom of the tumor. And step 3, request an expert dermatopathology review, especially for those unusual spindle cell, pagetoid, sebaceous, or neuroendocrine tumors.
Okay, wait. Why does the depth of the biopsy matter so much at this stage?
Well, because a shallow sample can completely underestimate the tumor's true danger. A shallow biopsy might identify a tumor, sure, but it can totally miss the deeper feature that actually changes its final name and risk category. That's why the central tumor needs permanent pathology.
Which brings us to Section 2, mapping the hidden edges. For a lot of these uncommon tumors, the visible edge simply does not match the microscopic edge. And that's exactly where margin-controlled surgery, like Mohs, comes in. It's about removing a tumor in mapped layers to examine both the outer and deep edges. If cancer remains, the surgeon goes back only to the exact areas where it's still there, instead of just carving out another full ring of normal tissue.
Right, so if it's that precise, why isn't Mohs just the default for every rare cancer?
Good question. It is one excellent way to answer a very specific question. Where does this tumor truly stop? But, it has limits. A clear skin edge just cannot replace lymph node staging, imaging, or systemic medicine when the specific diagnosis calls for them.
Let's look at a concrete example. Dermatofibrosarcoma protuberans, or DFSP. It's typically a rooted local margin problem. The best mental picture here is really a root system. That plaque or nodule you can see on the surface, it might not show every thin root extending way down beneath it into the fat. And these numbers brilliantly illustrate the value of margin mapping. In pooled observational studies for DFSP, local recurrence was just 1.5% after Mohs, compared to 9.4% after wide excision. Wow, okay, so Mohs is basically the absolute guarantee for DFSP then? Actually, no. These groups were not randomized, so the numbers don't guarantee a perfect individual result. But they do strongly support having a margin control discussion. That is, assuming the tumor isn't a deep, recurrent, or fibrosarcomatous variant. That would require a totally different sarcoma operation.
So are there other local tumors that require that kind of intensive mapping?
Yeah, definitely. Extramammary Paget disease, or EMPD, is a great example. It's a rash-like cancer, often mistaken for eczema or yeast, and it frequently extends way beyond what you can visibly see. So, margin-controlled surgery deserves early consideration here. However, EMPD also requires a completely different evaluation. We have to check for invasion and deeply investigate whether it might actually be connected to a nearby internal malignancy.
Okay, let's reset for a second here. We've talked about mapping local margins and checking roots for things like DFSP and EMPD, but what happens when a rare cancer doesn't just stay local? Like, is surgery the whole plan?
And that is exactly the question we need to answer next, because for a lot of these tumors, surgery is really only the beginning.
Which brings us to Section 3, expanding beyond the skin. When we look past the local area, we face the reality that some tumors require a much broader approach. We're talking scans, lymph node staging, and systemic treatment. Let's see how this builds by comparing 2 related diagnoses: atypical fibroxanthoma, or AFX, versus pleomorphic dermal sarcoma, or PDS. A true AFX stays right in the dermis as a local issue. PDS, on the other hand, enters the fat or shows aggressive features, like necrosis or lymphovascular invasion.
Look at the difference a single word makes on a pathology report. In a nationwide cohort, the 5-year metastasis rate was just 0.8% for AFX versus a massive 16% for PDS.
16%? I mean, that completely alters the treatment plan, right?
It completely shifts the entire conversation.
For AFX, local tissue-sparing surgery like Mohs is often perfectly reasonable, but PDS, that demands a full multidisciplinary sarcoma plan involving scans, radiation consideration, and structured surveillance.
We also see highly specialized needs with microcystic adnexal carcinoma, MAC, and sebaceous carcinoma. MAC can track deeply along nerves, which means numbness or pain might lead to an MRI, a larger operation, or even radiation. Sebaceous carcinoma, especially when it's right around the eye, might necessitate coordinating with an ocular oncology team, assessing lymph nodes, and sometimes even doing a hereditary cancer evaluation for things like Muir-Torre or Lynch syndrome.
Now we have Merkel cell carcinoma, or MCC. This is a seriously aggressive neuroendocrine tumor. Its treatment plan absolutely must address the skin tumor and the regional lymph nodes right from the very beginning. For clinically node-negative MCC, a sentinel lymph node biopsy should really be coordinated before definitive skin excision whenever feasible. But what if the MCC tumor is really small? Can we just skip the node check then? No way! Small size definitely does not eliminate the nodal risk. Get this, in 153-patient study, 25% of Merkel cell carcinomas, 2 centimeters or smaller, actually had positive sentinel lymph nodes. That is exactly why sentinel node staging, alongside permanent pathology and potential systemic care, is so absolutely essential.
Now, what's really interesting about these findings is how they summarize everything we've just been talking about. Finding PDS instead of AFX, metastatic risk is higher, requiring sarcoma surveillance. A node-positive EMPD, that requires site-specific oncology care. Periocular sebaceous carcinoma adds eye surface mapping and radiation questions. And any Merkel cell carcinoma demands sentinel node and medical oncology planning. These specific findings automatically bump a patient out of a Mohs-only pathway and right into broader staging.
Okay, so this leads to a very logical question. With all this mapping, staging, and coordination happening, when does the patient actually get reconstructed and stitched up? Right, which brings us perfectly to Section 4, timing reconstruction and teamwork.
Because of the sheer complexity of these pathways, the multidisciplinary team might include a dermatologist and dermatopathologist, a Mohs surgeon, surgical oncology, radiation and medical oncology, plus reconstructive expertise. Because there are so many moving parts, delayed reconstruction is often the safer choice. Reconstruction should really only be planned after permanent pathology, nodal staging, and true oncologic clearance are entirely secure.
So, the absolutely crucial point to remember is this. The best plan is not the one with the most specialists. It is the one in which every specialist has a diagnosis-specific job. At the end of the day, precise coordination always beats rushed surgery.
Expert Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together. We definitely invite you to read the complete Skin Trust explainer to discuss individual decisions with your treating clinician. So when facing a rare diagnosis, what hidden features might your pathology report reveal? Join us next time as we explore the specific mapping techniques used to catch the microscopic roots of skin cancer before they spread.